Hello everyone, this is Amandeep Arora. I am a uro-oncosurgeon at the Tata Memorial Hospital in Mumbai, and today we will be discussing about non-muscle invasive bladder cancer. Broadly, bladder cancer is subdivided into two categories: non-muscle invasive bladder cancer and the muscle invasive bladder cancer. The muscle that we are talking about here is the detrusor muscle in the bladder. A cancer which has not invaded into the detrusor muscle of the bladder does not yet have the potential to spread out of the body. And that is why the treatment that is done for these patients is not cystectomy. We do something called as intravesical therapy for them. But all non-muscle invasive bladder cancer patients are not the same. They are categorized into low-risk patients, intermediate risk patients, and high-risk patients. Now, how do we do that? This is done based on the histopathology findings that we have after we have done a TURBT in these patients. So we take into account the grade of the patient, the depth of invasion of the tumor, and some other parameters like the presence of carcinoma in situ, whether LVI is present or not, and then assign a risk category to a patient depending upon multiple online calculators that we have, and this is all guideline based. So finally, if your patient falls into the low risk category, this patient does not deserve any more treatment. But this cancer still has the risk of coming back. This cancer is not lethal, it will not harm him, but it still has the risk of coming back. And that is why these patients need to remain on follow-up. And how do we follow them up? We do that with the help of a check cystoscopy. No imaging, be it USG or a CT scan, and no urine test is as sensitive as a cystoscopic examination of the bladder to pick up a small recurrence. And that is why we do check cystoscopies in these low-risk patients. We do our first cystoscopy at 3 months after the TURBT, and then again at 1 year, and then it is done annually for 5 to 10 years. Coming to intermediate risk patients, these patients do deserve some more therapy. We cannot just keep them on follow-up. It then depends what is the therapy that we want to do. So our intermediate risk patients and high risk patients are different. In our high risk patients, they deserve a longer therapy and a more intensive therapy compared to our intermediate risk patients. In our intermediate risk patients, we have two options. We can either use intravesical chemotherapy, and the drug that we most commonly use is mitomycin C. And the other option is intravesical immunotherapy, and the drug that we use, and the only drug that we use, is BCG. So what do we do? It's given intravesically. So we decide whether we want to give mitomycin C to our patients or BCG to our patients. We give a schedule to our patient. So both these therapies consist of an induction phase and a maintenance phase. In the induction phase, we give 6 doses in 6 weeks. So one each week for 6 weeks. And then there is a maintenance phase which goes on for 1 year. So patients come to the OPD, we catheterize them. We first ask them to pass urine, they empty their bladder, then we catheterize them, then instill the chemotherapy or the BCG, then ask the patient to retain the drug in the bladder for at least 2 hours, if not possible at least for an hour, and then the patient passes urine spontaneously and the drug is removed from the bladder. This does come with its own share of complications. Mitomycin C is very well tolerated by patients. Not a lot of them, have complications. But BCG is something which has complications, and we'll discuss that when we come to high-risk patients. In our high-risk patients, we do not use intravesical chemotherapy. We use intravesical BCG only. What dose do we use it at? So BCG is available as 40 mg vials, and we use it at a dose of 80 mg. That is 2 vials per instillation. We start this therapy at least 2 to 4 weeks after the TURBT was done, because we allow that time for the bladder to heal from inside and then put in the drug. So the same thing, the drug is available as a powder. We reconstitute it in distilled water or saline, and then it is instilled into the bladder via catheter, in an empty bladder preferably, and then the patient is asked to retain it for a couple of hours, and then the patient passes urine. We do give a course of antibiotics along with this procedure, but it is just 2 antibiotics, 1 dose and another dose after that. BCG has its own fair share of complications. About 2/3 of our patients would experience some kind of mild discomfort. They would have frequency, urgency, they can even have some hematuria, and they can even have mild fever. But most of these are self-limiting, and the patient comes back to normal in about 48 hours, 24 to 48 hours. A certain category of our patients, about 1/3 of our patients, these symptoms get prolonged, and they may take around 3, 4, 5 days to recover from it. And then it is our clinical decision whether we give the next dose of BCG or delay it by a few more days to allow the patient and the bladder to recover and heal. A minority of patients, but a substantial minority of patients, have such severe side effects that they need to go to pass urine every 10-15 minutes and they are having massive bleeding and their fever is not stopping. And in such patients, we choose to completely defer BCG further. We give them some drugs, antibiotics, bladder relaxants. Some may even need steroids to relax the bladder and to take care of the immune reaction. We allow them to recover. It may take a couple of weeks, but then we do not try to re-challenge them with BCG because then it can have systemic side effects also. So that is more or less the gist of it. We have low risk patients with only cystoscopic follow-up. We have intermediate risk patients in which we have two options, either intravesical chemotherapy or intravesical BCG, which is given for a period of 1 year. In our high risk patients, there is only one option. We give intravesical BCG and it is given for a period of 3 years. Patients can still have recurrences when they are on the therapy. If somebody has a recurrence on chemotherapy, we switch to BCG because it's a more effective agent. If somebody has recurrence on BCG, the first treatment that is offered to the patient is a cystectomy, that the bladder needs to come out. This patient is labeled as having BCG failure. But some patients are not so willing for having their bladder removed, and in them we are recently beginning to try another option, and we use two chemotherapy agents in them, gemcitabine and docetaxel. So we do sequential instillation of gemcitabine and docetaxel in these patients. We have recent reports which are telling us that this might help patients to pull on for a year or two more without having their surgery done, but long-term results are awaited. Thank you so much.